Well, thanks so much for joining me today for episode 4 of season 2 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. So far during season 2 of the Healthy Skeptic MD, we have taken on key common medical decisions that many of us will need to consider at some point in our lives. So far, we've talked about a daily statin cholesterol medication to lower cardiovascular risk. We've talked about the value or potential lack thereof of routine annual lab tests. Last week, we talked about the pros and cons of ear tubes and tonsil surgeries in young children with ear, nose, and throat issues. And we're going to continue this focus in later weeks of this season, including next week with a really good episode we have planned on genetic testing. But this week, we're going to take a break from this focus. We're very lucky to be joined by Kristina Fiore, who runs a new investigative healthcare journalism unit at MedPage Today. For those of you not familiar with MedPage Today, it is a excellent health news organization that's really grown in prominence in the healthcare professional community over the last couple of years. With Kristina today, we're going to go through a number of stories that she and her team have covered since 2019, when her team was formed. As a bonus today, we are going to conclude with a short interview with Shelly Rosenfeld, who co-directs a really interesting program that I recently learned about. It's called the Cancer Legal Resource Center. They help to advocate for patients with cancer, so we'll get a chance to hear a little bit about what Shelly and her team do at the end today. To make sure we have adequate time for these two really interesting interviews, I'm going to dispense with the health news summary of the week so we can jump right in. But if you do find today's discussion engaging, if it helps you take a more active role in your health, please do subscribe to the Healthy Skeptic MD wherever it is you listen to podcasts or on my YouTube channel. Please also share it with friends and family and colleagues who might be interested in these health topics. And if you do have a chance, it's great if you could consider leaving a review wherever you listen to podcasts or on YouTube or anywhere else. So with that, let's jump into our interview with Kristina Fiore. Welcome to the show. Thanks for joining me today, Kristina Fiore from MedPage Today.
Thanks so much for having me. I'm really glad to be here.
Okay, so MedPage Today is a journalistic outlet really targeting mainly the medical audience, healthcare professionals, although there is some lay audience, articles as well. Could you just begin by telling my audience a little bit about what is MedPage Today?
Sure. So MedPage is essentially a clinical news service for physicians and other healthcare professionals. But we definitely do have a consumer audience as well. I've called it a prosumer audience. They definitely like the more technical, more scientific detail that we go into. MedPage started about 15 years ago. It's hard to believe it's been that long, but we've always sort of focused on two major areas, and the first is clinical news, and the second is health policy news. So we have a dozen beat reporters who follow their specialties, and I would say have as much expertise as many of the people who are, conducting the clinical trials and such. Cardiology, oncology, endocrinology. All of our reporters have followed their beats for a very long time and have a very real depth of knowledge in each of those specialties. And the same goes for our health policy people in DC. They all, if you need to know what's going on in health policy on the Hill in DC, our Washington coverage led by Joyce Frieden it's superb. She knows everything that's going on in DC, and also she covers all the agencies, so CMS, etc. So those two areas have really been kind of the staple of MedPage Today and our news. But in recent years, we've sort of been branching out into getting more of a clinician voice on our website. And that is, you were sort of one of the first with the Slow Medicine blog. We brought in many more physician contributors since then. And we now have an editorial board of a variety of physician voices, from key opinion leaders all the way to people who are very active on social media and who are sort of kind of the next generation of medicine. And that editorial board is led by our new editor-in-chief, Marty McCary, who is very interested in the costs of healthcare, the business of medicine, and those sorts of things. And that has informed sort of this newest venture that we're doing, which is our own in-house enterprise and investigative reporting team.
Yeah, that's great. And I have to say, MedPage Today has really grown in prominence. 5, 7 years ago, it was not widely known, but now almost every medical professional is aware of it. Many of us get subscribed to the blogs. As Kristina mentioned, I did used to write a slow medicine blog for MedPage Today, and that actually really is the precursor for this Healthy Skeptic MD podcast, which targets more of a lay audience. And Kristina was my editor, in full disclosure, so she did a great job with that. But I do want to talk a little bit, Kristina, about this investigative unit that you have started leading over the last year at MedPage Today. Journalism right now, there are fewer and fewer reporters who are funded to do this hard-hitting investigative work. Tell us a little bit about why MedPage Today decided to invest in investigative journalism.
So MedPage has always had a commitment to investigative and enterprise reporting, and a lot of that came through our relationship with John Faber of the Milwaukee Journal Sentinel, who I would say is probably, the top reporter when it comes to conflicts of interest in medicine. He is the expert on that. So I had the opportunity, as a junior reporter to do a lot of work with John. More recently, John had taken a fellowship with the Night Science Journalism team at MIT. So our new editor-in-chief, Rachel Warren, really wanted to have an in-house team while John was doing that work. So I have to admit, I had actually taken my career had taken a different course, and I was doing internal communications at a pharmaceutical company for a couple of years. And Rachel had called me and said, "Hey, I really want to make this in-house commitment to enterprise and investigative, and would you like to come back and build it?" And so, of course, I was missing journalism at that point, and I said, yes, absolutely. So that was in July of 2019, and we started out with, just 2 reporters and 1 freelance contributor, Cheryl Clark, who's actually won numerous healthcare awards for all the great investigative reporting work that she's done. And now, a year and a half later, we're 5 full-time staff reporters strong, and Cheryl is a regular contributor along with several of the freelancers. So it's been really interesting to see that team grow, and we cover a range of things, everything from like a newsy piece based on something that's breaking big on social media. Twitter is a huge source for us, all the way to feature stories, profiles, as well as bigger science features, like this piece on ivermectin that I believe we're going to talk about later. And then we go all the way up to large investigations that we work on together as a team. And I think we'll cover some of those as well. So while we do a range of different pieces, we have a North Star. It's certainly heavily influenced by the work of our editor-in-chief, Marty McCary, who cares very much about the problems with, the rising costs of healthcare today. So all of our stories, well, not all of them, but most of them tie back in some way to, the corporatization of healthcare, physicians feeling like they have no voice, that they have to serve administrators and shareholders above their patients, unfortunately. So, and overuse and overtreatment, I think, really comes into play as, a big piece of that puzzle.
So we're going to get into a number of the specific stories you've covered in the investigative team, but I do want to start with that overuse. You and I have shared an interest, and it definitely seems that one of the themes of MedPage Today is trying to address the issue of too much medical care and the harms that result from it. I remember you wrote a great article in the Milwaukee Sentinel a couple of years ago on illness inflation, the over-medicalization of common complaints that all of us have, like a little bit of reflux and so forth. Maybe you could just start by telling us a little bit about, do you agree that there is too much medical care? And is that a problem out there now?
It certainly seems to be. I think, with illness inflation, what happened was we found, it was really John Farber's idea. He said, there are so many conditions now that were not conditions just 10 years ago, 20 years ago. So we were like, yeah, well, we should look into what those conditions are and figure out how they came to be, and why their diagnoses now when they weren't just not that long ago. So we found 8 conditions that we did deep dives into their origins, and that was overactive bladder, low testosterone or low T, and prediabetes. Those were the medical conditions, and we found a lot of psych conditions and psychiatric conditions that we thought were a little questionable. So those were binge eating disorder, adult ADHD, intermittent explosive disorder, premenstrual dysphoric disorder, and hypoactive sexual desire disorder. And what we found with a lot of these was that there was usually some type of therapy being pushed or trying to be approved. And that's when these conditions sort of came about. So for instance, with overactive bladder, that was one of my favorites to do because it was sort of like the playbook for creating a disease, which not my words, it was the words of a sales and marketing executive at the company. We found a slide deck from this individual that labeled the whole story, creating a disease. And in the late 1990s, early 2000s, 2 urologists we found who had financial connections to a number of companies, but at the time, Pharmacia was trying to get Detrol approved for a new condition called overactive bladder, and it just showed how these individuals organized meetings with lots of other key opinion leaders, and how they would do things like editing journal supplements focused on this condition, which they coined the phrase for it. Before that, it was only incontinence. There was no such thing as overactive bladder. And ultimately, their contributions to making this condition accepted and getting definitions changed and expanded, Detrol was ultimately approved for this condition, which we're still seeing the effects of that today. The ads on TV with the little cartoon bladder that runs around pulling the people away from their bowling games or whatever it is. A lot of people would argue that perhaps this is just a condition of normal aging, that you run to the bathroom much more frequently. But clearly there was a lot of influence, a lot of pharma money behind bringing this disease to the market.
Well, that's why the article really resonated with me, because I see this as a primary care doctor on a day-to-day basis. I started, for example, seeing more people coming in, as you said, exactly with overactive bladder, which I think maybe in the past they might not have necessarily raised. And I'm always torn with, you want to take patients' concerns seriously, and if there's something that's bothering them, there's something we can do to help. But on the other hand, there's certain things that it's better just to do your best to ignore them, and with time, let time get better rather than starting a medication, with side effects. So it really hit home, that series for me.
Yeah, I think that a lot of our readers were saying the same thing, that it's hard for you as a physician when you have a patient in front of you who is saying, I saw this medication on TV and I think this will help solve my issue. And it's very hard to be able to dissuade them and say, if you just try, changing your diet or exercising or something like that, it's very hard to say, take that instead of this pill that's supposed to be scientifically proven to work for the thing that you think you have.
Yeah, actually, I'm on the Pharmaceutical and Therapeutics Committee at one of the groups that I work with. We decide what medication should be on formulary, and we were talking about ADHD medications and the explosion of these. And it was so funny. All of us had said that we've seen more adults requesting ADHD medications over the last 3 years than we have the entire rest of our careers combined. It's just been an explosion of people who are having trouble concentrating when, 5 years ago would have just passed it off as, I need to exercise more or, meditate more to improve my focus. And now they're coming in seeking stimulant medications which have a lot of side effects.
Yeah, and that was one of the conditions we looked at. And again, it was that same pattern of, experts who were kind of flooding the medical literature with evidence of, a condition called adult ADHD. And, was it really I don't remember the criteria being very, they were a little bit squishy. And that's what we saw with a lot of these conditions.
Yeah, well, your team's done a great job of tying both the clinical issues to the financial incentives, like you just said, some of those conflicts of interest that drive, some of these FDA guideline decisions that lead to the clinical patterns that we're seeing with overuse. Well, I want to jump to COVID-19. You've covered that a lot with your team. There's been one, treatment after the next that's been pitched as the miracle cure to COVID. We heard about hydroxychloroquine for a while, a number of others. The latest one is ivermectin, which is a medication used to treat historically parasitic infections. And your team just did a really nice article covering that with a skeptical take. Tell us a little bit about ivermectin and how it's been proposed to be used for COVID.
Yeah, so, there are many, many drugs that are being looked at that are, repurposing for a role in COVID-19. And we tend not to even get into it because there are just so many. And we don't want to bring anything up until we have evidence and data behind it. But ivermectin, we were getting a lot of comments from readers. An old story from the summer that we had done that had mentioned ivermectin was getting a lot of traffic. So we're like, what? Why is this? What's going on? Where is this coming from? So we decided to look into it. And what we found was that a group called Frontline COVID-19 Critical Care Clinicians, or FLCCC, they had done their own review of the global literature on ivermectin. And they said that based on the evidence that they saw, that we should be providing this widely, especially during a pandemic. We don't have time for our old systems of evidence-based medicine. This is wartime medicine. We should just be prescribing something that looks like it will likely help based on this body of literature, this global body of literature, and that we know is relatively safe. I interviewed a lot of people. Not a lot agreed with that interpretation. And I imagine if you're on the front line, you really want to be able to help patients, but it came down to just saying, no, we've been burned. We really need to stick to our evidence-based criteria before we move ahead with this medication.
Well, I know it sounds trite, but we've learned over and over again that those lower quality non-randomized trials, they're interesting, they might be suggestive, they can give you a hypothesis that requires further testing, but we really should not be making firm clinical decisions based on that. And as you said, during a pandemic, if you're a frontline doctor and you want to do everything you can to help your patients, certainly I feel that when I have my patients in front of me, I want to give them something. But we just have to remember history, and that most of the time these initial positive signs don't prove to be valid when you do the rigorous follow-up studies. So we need to do those studies to pick out the treatments that really do work. So I appreciated the article on ivermectin highlighting that exact point.
Yeah, there was only one trial in the U.S. and it was a case control, and the patients had gotten other things besides just ivermectin or placebo. So yeah, I think that's what everyone was saying.
Yeah, the other topic you've covered quite a bit during COVID-19, your team is testing. There have been a lot of experts who have made the case that we really need to ramp up testing, and maybe that's the way we get out of this pandemic until a vaccine comes along and is widely distributed. But this sort of idea of testing everybody all the time also may have some downsides. There can be some false signals that can lead us astray. And you've written about how some of these tests are not as accurate as sometimes they've been purported to be. And I just love your general thoughts on the role of testing in this pandemic.
Sure, it's certainly evolving. When we first reported on testing, what I wanted to do was just look at, well, hey, how sensitive and specific are these tests? And what we found was that, they're not FDA approved, they're authorized. It's an emergency use authorization. So they didn't really have to do very extensive testing to really find out sensitivity and specificity. And when we look through the EUAs, all the PCR tests had almost 100% sensitivity and specificity. And of course, that's under very controlled lab conditions. The antigen tests were a little bit lower than that, but they were still in the high 90s. So we were like, okay, well, that doesn't seem really helpful. How is this going to play out at a population level? And it's turned out that testing really hasn't had the role in the pandemic that we initially had hoped or thought it could. I mean, it just got too big too fast. Being able to test someone, quarantine them, and test their contacts just would not be feasible for most places. There are a couple of changes that I've been interested in. There's been a movement, it's really led by Dr. Michael Mina at Harvard for antigen testing, which we all know has caused problems in the White House. The Binax now was the one that was reportedly used when there was the outbreak due to the Rose Garden ceremony. But Michael Mina's argument is that if you're doing it correctly, these could be really useful for sequential serial screening programs every single day being tested with a rapid test. You'll get your results in 15 minutes. You could do it at home with something like a Binax now, which is a little card. It doesn't require any big machinery. If you're, you can test a school that way. Every student has to test themselves before they go into class so that no one's coming in and spreading the disease, because that's where these antigen tests seem to be much better, much more sensitive in terms of picking up someone with an active infection. The problem is we don't have data on any programs like this, but I've talked to many places that are implementing this, like Washington State. I was talking to their epidemiologist last week, and he said that a school there is using this, is testing this right now. So when those data come out, I'll feel a lot better about saying, okay, maybe this is actually a really helpful and effective public health tool in terms of preventing transmission.
Yeah, I'm also really interested to see how that pans out. If there really truly is a very cheap home test that everybody can do every day of the week, I could potentially see some benefits of that, but there are also risks. If we get false negative results and that gives people the confidence to go in and expose others, it could actually backfire. The other thing is you have to compare that, the resource investment of doing an initiative like that with some of the other things that we could be doing. So I think you have the right perspective. Let's see how it goes in a couple places before we make any conclusions. Now, your team also, Kristina, did a recent excellent series of articles on a device called NovaSure. This was marketed as a quick and easy solution to too much menstrual bleeding. Could you tell us a little bit about the device NovaSure and what your team uncovered?
Yeah, so that was a really interesting investigation we'd done based off of an email tip that we got. A physician had written to us and said, hey, I'm seeing a lot of infections with this device called NovaSure, which is used in endometrial ablation. Basically, it destroys the uterine lining so that women who are having heavy bleeding, so the idea is that it would reduce that. And it would potentially prevent women from having to go in for a full hysterectomy, which is great. We've heard a lot about hysterectomies being overused and, done unnecessarily. So the idea of this device was actually, it sounds like a good thing. But what we were finding was that there was quite a bit of harm. After that tip, I was looking into the literature and I found physicians who were saying that it was causing many problems and that women were still, down the line, their periods would come back, they'd come back worse. A big complaint was this cyclic labor-like pain. And I couldn't imagine a woman being in labor-like pain once a month. We heard many stories like that. So it was just, seemingly was doing more harm than good. We found some Facebook groups with women who were experiencing these symptoms. But the problem is it was really hard to quantify. We didn't know how many endometrial ablation procedures were being done in the U.S. in any given year. NovaSure is certainly the most popular device. We know it has at least 60% of market share from some prior, data firms and their reporting, but we think it might have more. So NovaSure being the main way that this was being done to women, we looked in the FDA's MAUD database, which is, it catalogs all adverse events with devices. It's supposed to. Companies are supposed to report to it. So we knew that NovaSure had done about 3 million procedures over its lifetime. We went through about 10 years worth of reports, and there were a lot in there. And what we found was hundreds of cases of things like bowel perforations, uterine perforations, follow-up hysterectomies that had to be done relatively quickly after because the procedure went wrong, bowel surgeries because when the device would cause that perforation, you'd need surgery to fix a gaping hole in your intestines. We saw cases of sepsis, and we even found 6 deaths, which is a small number, but it's unfortunate that this procedure that's billed as a literally 90-second quick fix, that's all it takes to do the actual ablation part of it. It can be done in your doctor's office, seemingly very safe. To have 6 deaths over 10 years, we were just like, okay, small numbers, but still that's not a good sign. So as we continued to talk to more and more OB-GYNs about this, they were saying, yeah, we think that it's being used a little too liberally. Like, the instructions for use of the device had many, many contraindications, and some very common ones like cesarean section or polyps. And there was talk that perhaps some users of the device weren't being as cautious in certain patients as they should be, maybe not looking at all the contraindications that well. We did find that there were some relationships between certain providers who would champion the procedure on their website. Between them and the device maker Hologic, we found Hologic had spent about $300,000 over a 3-year period on key opinion leaders and influencers. And there was one in particular in Indiana whose website was, very promotional for endometrial ablation with this device specifically, and she had made $175,000 over 3 years from Hologic. So, there were other incentives for doing the procedure too. It pays about $1,000 per procedure, and if you can do it in your office, that's very easy income. So there were a lot of bad incentives for physicians to be performing this procedure on more patients than perhaps they should have, and that was kind of the main finding of our study. We also found several OB-GYNs who were very vocal about not doing them anymore because they'd seen too much patient harm. So that helped build the case about why there was a real need for being a little bit less liberal with doing this procedure.
And is NovaSure still on the market? Is it still used?
It is. Yeah, it's still out there, along with a handful of other endometrial ablation devices, but NovaSure is definitely the most popular.
Well, a couple weeks ago, we had Dr. Rita Redberg. She's a cardiologist at UCSF. She's editor-in-chief of JAMA Internal Medicine. And she's done a lot of work about how devices are regulated very differently by the FDA compared to medications. And medications go through a rigorous review process. Only they require rigorous randomized trials to confirm that the benefits outweigh the risks. But with devices, the FDA has a much more hands-off approach. They actually don't even, I believe, technically approve devices. They just clear them. So it's a much lower bar. And I think that catches a lot of people by surprise because in some ways, devices are just as dangerous, if not more potentially dangerous than a medication. Some of these devices are implanted in you. Others, as you said, there's potentially direct harm to the uterus in this case. There's been a lot of calls for stricter regulations by the FDA for medical devices, and I think your series of articles on this is a classic example for why this might be needed.
Yeah, thanks. I mean, I think at this point, the impact that we're hoping we've had is that maybe this will help inform women who are considering the procedure. So at least we have that, and I'm pretty sure that other OB-GYNs who've been reading it may be thinking twice about doing the procedure without really good patient selection beforehand. So hopefully, if the regulation side doesn't come in, at least maybe we can have a small impact that way.
Yeah, and it also relates to the illness inflation discussion that you were having. And I'm not in any way downplaying that abnormal bleeding or heavy bleeding can't be a real irritation or an annoyance. But you always have to weigh, is this procedure, the risks of this procedure going to outweigh, the benefits going to outweigh the risks? And in some cases, maybe just waiting a little time for things to improve or trying a more conservative treatment option may be better than taking on the risks of a procedure like this.
Yeah, I think that's absolutely the case. I mean, we've seen, there are many conditions that can fit that bill. I mean, I have so many other examples that have come across in the last 10 years or so that I've been in this. One that Marty McCary, our editor-in-chief, has written about. It's actually kind of the opening of his book. The whole issue of peripheral arterial disease and placing either ballooning, leg arteries or placing stents. And, there's really no evidence that this will help circulation or prevent future cardiovascular events. And yet, Marty and his team found that there are some cardiology practices that were actively recruiting, essentially, patients, and they were going into churches in African American communities doing free health screens. They were doing blood pressure screens, and they were asking people if they had leg pain. And if they met those criteria, high blood pressure and I think it was the ankle brachial index, they would refer them for a visit. And that visit, they would, either just do, ballooning, opening artery, scoping the arteries to look first, which is a procedure on its own right, and then doing a ballooning if they needed to open some up, or stenting. And we've seen this issue with a lot of other cardiovascular issues too, like, stenting for angina, or carotid artery stenting, which is also, things like this have turned out to not be beneficial in randomized controlled trials. And yet there's still a drive for these things. And there's still some, these recruitment strategies are a little bit questionable. It sounds like they're doing a great thing with these health screenings, but, they're really, maybe not doing any help, and who knows if they're causing harm. So
yeah, there was actually the peripheral artery disease one is a great example. There was a study by the Dartmouth Atlas Health Group a couple of years ago that looked at variation in the rate at which peripheral artery procedures were performed. And there were some regions of the country, typically urban areas like Los Angeles and Houston, Texas, and Boston, where these procedures are done at 3 to 4 times the frequency per thousand population as compared to other regions. There was no evidence that it was actually leading to better outcomes. The vast majority of people with peripheral artery disease, it's not a surgical procedure they need. It's stop smoking, exercise more, and eat healthy. And the amount of value you'll get from that is just tremendously greater than you would get from a surgical procedure without any of the risks. So I'll have to check out that book. That sounds like a great example of exactly what we're talking about. Well, Kristina, I have one last question for you. You are a journalist, a health journalist. You come at medicine from a very interesting perspective. The goal of my podcast is to help people be more engaged, good consumers of healthcare services. Based on what you've learned as a reporter, what advice would you give to somebody about being an engaged, effective healthcare consumer?
It's certainly not easy. I think people are up against a lot when it comes to trying to make really good decisions about their healthcare. But a couple of things that I would do if I was searching for a procedure, I would certainly I think it comes down to being your own advocate. Like, you have to take the decision making into your own hands and do as much research as you possibly can with good, reputable sources. I think search of PubMed to try to see if your procedure that you're considering is controversial, if there's, any back and forth about why it may be helpful, why it may be unnecessary. I think, an easy way to do that is with PubMed. You don't really have to read the entire study to get a sense of, in the abstract, if there's some tension in the community about how frequently this should be done, or if this shouldn't be done, or if it's actually beneficial. I would say find out to see if there are any alternatives to a more medically intensive procedure. Like, I've heard many instances of back pain where surgery was recommended right away, but people were able to fix their issues with exercises on their own. If not physical therapy, obviously starting usually with PT, that's where the exercises are prescribed, but then being able to do the regimen at home and, never needing the back surgery, never having back pain again. I would say an important thing is getting second opinions, but not necessarily from people in the same field, right? So if you are considering that back surgery, don't just talk to the surgeon. Talk to your primary care doctor. Maybe your OB-GYN, your urologist is your primary care doctor. Talk to someone who has no stake in the outcome, or no stake in the procedure, essentially. Obviously, the outcome is to get you better. But really understanding incentives and, what might drive the use of certain procedures, I think. It's not an easy thing to understand or to find out, but it's really key. And I guess it comes down to having that provider in your corner who will always be able to tell you the full context. Like a long-term there's no stand-in for a long-term relationship with a good primary care doctor. I think that really is very, very helpful.
Yeah, those are great tips. And one that I really like that I don't think is said enough is get a second opinion from someone not in the same specialty. There's that famous saying that if your tool's a hammer, the whole world looks like a nail. So when someone has chest pain, of course, the first person they want to see is a cardiologist. But in many cases, it's a general internist, who can actually give you the most balanced perspective on that issue. One caveat being sometimes primary care doctors have networks of referrals, and they may feel pressure. I do sometimes, if a surgeon I work very closely with recommends a procedure, for me to go against his or her recommendation. I always do what's best for the patient, but it is a little challenging for someone that you work closely with. So don't be afraid to go outside of your network to get someone who's totally disconnected from the situation to weigh in on the opinion.
Yeah, that's a really important extra layer to that for sure, which is why I think it's just so critical to be able to have a relationship with someone you completely trust, and you know that they're always coming from a physician that you really trust, and they're always coming from a place of your best interest, and and not outside forces. So,
well, thank you so much, Kristina, for taking the time to join the Healthy Skeptic MD today. We'll really enjoy your work on MedPage Today. I recommend, if you're not familiar with this publication, check it out and check out Kristina's work in investigative journalism, because, as I said, there's fewer and fewer journalists out there doing it.
Thanks so much, Mike. It was so great to be here. I really appreciate you having me.
Okay, so that was Kristina Fiore from MedPage Today. As I mentioned at the start, we have a bonus interview today, and so now I'm going to bring in Shelly Rosenfeld to tell us about the work she does with the Cancer Legal Resource Center. Welcome to the Healthy Skeptic MD, Shelly.
I'm so glad to be here. Thank you for having me.
So I thought this would be a really good way to end the show today. I recently found out about the Cancer Legal Resource Center, a great program that I thought has a lot of benefit to a lot of patients. And so I just wanted to give everybody an opportunity to learn a little bit more about it. Shelly Rosenfeld is the co-director, where she's been for the last year. And it's a subsidiary of the Disability Rights Legal Center, which is your parent organization. Can you just tell us a little bit about the Disability Rights Legal Center?
Sure. So the Disability Rights Legal Center is a nationwide nonprofit, of which the Cancer Legal Resource Center is a program, and we help people across the nation. They can have $1 million in the bank or $1 in the bank. We help them for free. We provide legal resources, information, both federally and for their state, that can be useful for them, as well as we refer them to legal resources in their area, such as legal aids or other organizations or specific entities that might be a governmental entity, depending on their situation, that would be helpful. And also, we have members of a professional panel, lawyers who are in various states. They're licensed in that state, and if we have someone in that specialty area, we'll also refer them, and they'll get a free initial consultation. So when someone contacts us, whether it's online or on the phone, we are there to help them, and it's all free, no matter what.
Who funds your work?
We are funded by a number of different ways. First of all, we're funded by law firms, as well as some pharmaceutical companies have patient support programs. So nobody that contacts us is ever charged, but there's certainly also, state bar organization support as well. So we're very thankful to those who support us, and of course, always happy to have support. But there's a lot of people out there that are hoping that those affected by cancer get the support they need when they leave the doctor's office as well, and have so many non-medical side effects.
And you are a nonprofit organization, I think I saw.
Yes, that's correct.
Okay, great. So tell us a little bit about the Cancer Legal Resource Center. I don't think many people think of cancer per se as a disability. How did the organization come about? So
what's really interesting, and you're absolutely right, those with cancer may have been in the best shape of their life before receiving cancer diagnosis, and all of a sudden something would change. And also, in some cases, if treatment is successful and they're in remission, they can go back to the health that they, their best health. So certainly someone might not consider themselves disabled, but under the American with Disabilities Act, and there are some definitions where under the law, someone may, due to the cancer treatment that they're going through, as well as their diagnosis, may qualify for certain protections under the law, for example, with the American Disabilities Act. So therefore, while it's separate from our parent organization in the sense of our day-to-day work, the cancer community has different needs, has different concerns, but there is some of the protections of the law that can be helpful, whether it's a student getting support in a classroom based on that as well as on their job in the job application process and at their job as well.
So maybe walk us through a couple sample cases. What is the type of reason that someone would reach out to you, and how could you help them?
Sure. So one issue that's very common is someone that has financial toxicity, and that's what's commonly referred to as someone that has financial concerns that are very serious after they receive their cancer diagnosis. So somebody that calls us, we don't provide financial assistance. But one way that people do oftentimes pay for their treatment is because of their income. They have a job. So we help them with resources of understanding how they can keep working at their job and that, and still go through their treatment. One example, and this is of course just broad strokes, is that they may be eligible to take time off under the Family Medical Leave Act. So if they qualify, and we walk them through that, then that person could take unpaid but job protected leave. And some people have procedures, they have to take time off work. But what if somebody doesn't need to necessarily take off, time from work, can stay at their job, but maybe just needs a few tweaks to their job environment. Maybe they're cashier and need a chair by the cash register to sit down every little bit of time. Well, that may, under the law, and certainly if they qualify under the American with Disabilities Act, to qualify as a reasonable accommodation.
And is it typically patients or providers who reach out to you, or both?
The most common is certainly the person diagnosed with cancer, or someone that's in their life, a caregiver, for example, a spouse, or someone, a child calling about their adult parent. That is the most common. But that's not to say that we can't help someone say, gosh, my patient is I'm concerned about this. How can I better become informed about this issue when I get patients that come to me with this concern? Also, and this is really important, I think directly applicable to every healthcare provider, is that we have a free patient legal handbook that goes over some of the most common legal issues that someone may face after a cancer diagnosis. And we have very succinct explanations.
So it sounds like you guys are a legal organization. You're a lawyer, but what you're actually, a lot of what you're doing is trying to avoid litigation. You're trying to problem solve, advocate for patients, provide education. Is that sort of consistent with your goals?
Yes, absolutely. We do not litigate. The Disability Rights Legal Center does take, high impact cases, does litigate. We don't, because I worked as a litigator. Litigation can be expensive. If somebody can avoid actually, ironically, going to a lawyer for their legal concern, but rather be more informed, then that's, they're already ahead of the game. And if they know their rights and know what might be out there, then they're in a good position. Now, there are some cases that might merit legal action, but there might be steps along the way that they can take before going that route.
Well, I have two final questions for you, Shelly. The first is you are a lawyer. You were telling me before you were doing entertainment law before you did this. What caused you to make this career shift into a focus on helping patients with cancer advocate for themselves?
Sure, it's certainly a different world, but I was a journalist before I became a lawyer, and the stories that I felt, some of the stories that were most meaningful for me were about health-related issues, because that cuts across every background. There's no way to kind of prevent it, so to speak, and so that was some of the most universally compelling stories were related to someone's health. And I had already volunteered a little bit with the Cancer Legal Resource Center while on one of my law school breaks. And I felt it was one of the most direct ways to help someone as a lawyer. And so when the position opened up to join the Cancer Legal Resource Center, I interviewed for it, and I'm so fortunate to be able to do the work I do.
Well, my final question for you, Shelly, you've seen a number of patients who are struggling, with cancer diagnoses and the logistical challenges as a result. What general advice would you give to somebody who, for example, has a new diagnosis of cancer, or a family member with a new diagnosis of cancer? What should they be looking out for, thinking about?
There's so much to think about when someone first has a cancer diagnosis, and depending on their circumstances, some issues might be more relevant than others. I would say first and foremost, someone should know their rights, that and to really just become they don't have to have a textbook knowledge, but just to become aware of the basics, that just because something might not be covered under their insurance, that doesn't have to end there. I do presentations and I always say, don't take no for an answer. Whether it's knowing that just because they have cancer, that doesn't mean that they can't be at their job anymore. So being aware of these broad strokes aspects of being able to know that they have rights out there, I think is already a great way for someone to feel secure that they can make a good decision for their situation. And of course, to call the Cancer Legal Resource Center.
And along those lines, how does someone get in touch with you? What's your website? How can they find you?
The best way to reach us is probably to go through our website. We have handouts there, previous webinars. They can find out about upcoming webinars, and of course, fill out an intake online. And they can do that. They can fill out an intake 24 hours a day, 7 days a week.
I typically don't try to highlight any single organization or product or anything like that, but your organization, it's a free service to help advocate for patients. I just thought it was a really neat one to highlight. So thanks for joining again, the Cancer Legal Resource Center. Check them out on the website. And if you think you could benefit from the help or know someone who does, definitely pass along the information. Well, thanks again for joining me this week for the Healthy Skeptic MD podcast. Please do search and subscribe wherever you listen or on YouTube, and leave us a review if you have a chance, and we'll pick it up again next week. Thank you.